We just went over this case that we placed 4 cages and 10 screws in about 1 hour and 45 minutes and corrected the scoliosis. This patient was discharged in very good condition just one night after the surgery. Went home about 3 or 4 weeks after the surgery. Patient had a hard fall and start having leg pain again. Patient was brought to the clinic and we actually got a CAT scan, and this is the result of the CAT scan that shows that the 4-5 cage has migrated a little forward. This cage was placed just on the rim of the bone all the way to the right side to correct for the scoliosis, but now this cage is halfway out. What we could show then is that in a second CT a little later that this cage has migrated even worse. To start again, this patient had a severe scoliosis that was corrected with transcambing OLLIF, but now after we corrected and patient felt leg pain that was gone returned, and we decided then after the second CAT scan showed that cage is migrating more to bring the patient back and correct the situation. Now we could go anteriorly obviously, but that would be a very big surgery, so we decided in this case actually to catch the cage through the same approach, left-sided approach, and as you see there is only very little of the cages left in this space. So what I do, I use a neuromonitoring probe to enter the disc, and here once the disc is entered I put a sleeve, a K-wire, and over the K-wire a dilator, over the dilator then a cannula, 8mm cannula is placed. Unfortunately I couldn't get a good grip with the pituitary on the cage because the cage was actually subsiding into the bone, and as well it was very difficult to get a K-wire in. Now what I did, I put a bend in the K-wire. I could reach the K-wire, the cage, but it wasn't good enough, so I increased the bend. As you see, I'm increasing the bend of the K-wire and entering and practically corkscrewing the cage or the wire into the cage. Yeah, in this moment I'm bending and entering and corkscrewing the wire into the cage. Then at this point then I remove the cannula. Then this is a threaded cage, so, and it's titanium, so the threading part is going in. I'm barely able to put half a turn into that, but when I'm trying to bring it back it disconnected right there. In the second time I go in, when I'm trying to screw it more into the cage, obviously the cage turns, and as you know there are a major vessel there, but those vessels are safe because the cage is truly a blunt cage. So I'm trying to screw it more into the cage, and here as you see I'm trying to wedge it against the bone, and then I'm able to, as you see it's advancing forward, put that completely. Now I'm putting another turn, so use the lower profile of the cage right here, as you see, lower profile, to pull it slowly back into the disc base and then practically remove it completely. So we can safely remove the cage, initial cage that was going out. I don't want to use the same approach because this approach has been severely compromised. So I go and do a right-sided OLLIF So practically I'm still on the left side, but I bend over, and over the right side I put a neuromonitoring probe in the same level. Then after we put a dilator and a cannula, I perform minimal discectomy because it already was done last time. So practically crossing the path of the first cage to be sure that it doesn't come out anymore. I put a second cage in. This cage as well is a very large cage. So for that reason I put the cage in the lower profile, as you see here when it goes in. And now once it's in, I rotate it to the final position. This is a 15 millimeter cage. Now it's important to note that this patient woke up, the leg pain was gone, and less than 24 hours after the surgery, this patient was discharged home in very good condition.